much.
Thank you very much for the introduction and invitation for me. I must appreciate Dr. Sharda Jain for inviting me, along with Dr. Asmita Rathore, and all of you. And it's a pleasure to share the dais with Ma'am Alka Kriplani and seeing Deepika, JB Sharma, and all my friends here. I would take you through. No, mine okay? Okay? आवाज नहीं है, थोड़ा बेंड करना है. Can you hear me now? Yes. I would take you through the topic of scarred uterus, which can get into preterm labor. But I would like to express my experience over the years, how we are responsible for the scarred uterus most of the time. Now, this is from our university building from Manipal. I'm from Karnataka state. Now, the scar on the uterus is definitely a concern and it's a challenge for us. Now, why I'm bringing that point is, it is one of all these scarred uterus you should not ignore because they get into preterm labor. But I'm not going to talk about that today. I'm going to talk about how we diagnose and avoid certain problems. I'm going to tell you next 25 minutes on all these topics, which can be a full 3 days conference, discussing all this. I will take you through uterine septal resection commonly done by many, myomectomy, adenomyomectomy, Asherman syndrome, scar ectopics, scar defects, scar endometriosis, placental adherent to the scar, rupture uterus, and avoiding preterm labor. I'm not going to talk too much about each. It will just about 2 minutes about each of them. Now, the purpose of this presentation is understanding the implications, how to prevent them, and how to prevent wounding the uterus in our clinical scenario. Now, septum, everybody, a young endoscopic surgeon or a gynecologist wants to remove all the septum. Madam Alka Kriplani would agree with me that all septum need not be removed. If it's a very tiny one, just leave them alone because you go and cut that, it will cause additions. So how do we know what to remove then? Eshrey has classified several things, but what I understand is the American Society of Reproductive Medicine in 2021 modified the 16 version, but look at the middle diagram. If the septum should be more than 1 centimeter, only then you remove. Something is very small, it may be actually arcuate uterus or maybe small subseptum. There is no need to remove, and don't go and cut a bicornate uterus just because you're thinking it is septum. Hence, a good 3D ultrasound and an MRI is done just to rule out a bicornate uterus. Now, the uterine septal resection and reproductive outcome. Septum is thought to consist of fibroelastic tissue with inadequate vascularization and altered relation between myometrial and endometrial vessels, thus exerting a negative effect on decellularization placenta. They have found significant reduction of number of miscarriages after cutting the septum, 91% compared to 12%. Increase in term deliveries after the cut of the septum, but while the number of preterm deliveries remained almost the same. What we should know that point is, just because we cut the septum, she becomes pregnant, but remember, preterm labor is a problem with these kind of patients because there are several reasons to have a preterm labor. Now, the postoperative management, they took 100 women. One group, they didn't do anything after septum. Another group, they gave estrogen. Third group, they put a copper T there. And fourth group, they put only copper T. Third group was estrogen and copper T. No reported difference in the rate of postoperative de novo addition formation assessed hysteroscopically, and there were no differences in pregnancy outcome. That means once you cut a septum, they don't need to do anything. She can become pregnant. Don't give something, all this waste of time, giving OC pills and so on for 3 months and 6 months, you're wasting time. But what we have also understood is, there are 9 comparative studies have been published, analyze miscarriage, pregnancy or live birth rate in women with a septate uterus who consented to hysteroscopic resection compared without anything. 3 of these studies showed a significantly higher pregnancy rate, but whereas the 6 found no significant difference. That means again, like a Cochrane study, pretty not sure whether to do it or not. That is why don't go cut a septum for everybody who comes there. Now, we have been doing a lot of myomectomy and adenomyomectomy. Today, I think I am showing videos like Madam Alka Kriplani, and for a change. And we are very fond of removing, but we don't know how to suture. So when we suture correctly, usually nothing goes wrong. And one thing is very clear. If you have cut open the cavity, please mention that in the notes. Whether it's open myomectomy or laparoscopy, age-old teaching. If you open the cavity, you should know. But why I'm bringing a new idea today. If you have opened the cavity, the adhesion in the uterus also forms. It's not only that you opened and closed. After some time, 3 months later, if you do a hysteroscope again, if it's a big cavity which you open, I'm finding some adhesions are present. So I've now introduced a relook into the uterus by hysteroscopy after about 3 months, because if you put a telescope early, a little adhesions can be cut. And if you don't do that, the adhesion becomes so much, she'll get into Asherman sometimes. So when you remove these myomas, adenomyoma, be careful about suturing. Now, lap myomectomy, if cavity opened, chance of intrauterine adhesion is possible. Hence, a post-hysteroscopic myomectomy, polypectomy or adisolysis, there's a recommendation now to do a second look hysteroscopy and prevent all these problems. Early second look hysteroscopy prevention of treatment of adhesions. Look at that blue what I put there. After a myoma, polyp and all these kind of things, 18% had adhesions. But if you removed a myoma from the uterus, it is 20%. Polyp, a small polyp, it can be 10%. And adisolysis, again it will form 26%. I had a patient, ma'am, just the last 6 months back. She had a very tiny polyp, not even 1 centimeter. Somebody has removed it and done a curettage, like those days we were taught, no, curettage, you must get the gritty sensation, DNC and so on. And she has come with completely adhesion. I put a telescope, it was total adhesion. One more thing is, don't remove all polyps, because a polyp may be there in one cycle, may not be another cycle. And if you go on giving estrogen for some time, for some replacement therapy, polyp will come, it will be a polypoidal endometrium. It's not a polyp. So anything less than 1 centimeter, don't remove. And I always tell that, go on removing that, it will cause problems. So adhesions, Asherman's is not uncommon. This is another case of mine, referred to me with so much of adhesion. I have done hysteroscopic adisolysis, and of course, that patient can again form an adhesion. So this is a very important issue. Once you have removed these adhesions, you can't leave her alone. In this patient, you must give estrogen and progesterone, not OC pills, but sequential therapy. You give 21 days of estrogen and add on progesterone in the last 7 days. Only then the endometrium regrows. If you give OC pills, it will suppress. So remember, these are the adhesions which can be removed, but you should prevent them by. So that can be sometimes adhesion in the uterus, or it can be the cervix. At another patient, they have done Asherman syndrome because of all these unnecessary polypectomy. The adhesion was even in the cervix. And she was menstruating every month, partly in the uterus, and it was getting collected in the uterus. Unbelievable. So that hematometra was coming up in a woman who was menstruating properly, and then unnecessary hysteroscopic adhesion was done. So the adhesions can be anywhere. It can be uterus, it can be cervix, it can be any of these areas. But what we should know is, we should regenerate the endometrium by estrogen after you do the adisolysis. The guidelines of the adhesions by AAGL and hysteroscopy is the most accurate method of diagnosis. I won't waste time, we do not do the other tests. Now I think we'll skip some of them. The classification is not necessary. But what people have found is, intrauterine adhesion management, 3 cycles of estrogen and progesterone is very good, so that there is generation of the endometrium and no further adhesion. But I sometimes would do another 3 months later, again at a hysteroscope, just to check whether everything is done properly or again some formation has happened, because earlier the better. The rationale of estrogen therapy is the same thing, to promote regrowth of the endometrium over the denuded surface. However, there are no evidence-based recommendations on optimal formulation or duration, in part because studies that compare different estrogen regimes in isolation from other therapies are lacking. So once again, emphasizing a repeat hysteroscope is necessary for all these kind of patients, so that we again do an adisolysis if there is one. We are finding a lot of ectopics these days. We never saw this long back. Ma'am, Dr. Jain would agree. Madam Alka, I don't think we saw so many, but now why is it coming up? Because again, suturing technique. Suturing is not being done. They're all doing this single layer and going off fast. Age-old 2-layer is quite good. That's why the scar, I'm going to talk next few minutes on this opening of the scars and so on. Now, if you get a scar ectopic, it can be endogenic or exogenic, means it is going outwards, exogenic. Endogenic means it's growing inward. So there can be different kind. Look at that. It can be just the grade 1 is the top one. You'll find a small little thing there. Grade 2 is it occupies 1/2 of the myometrium, and grade 3 is occupying the full myometrium, and grade 4 is an amorphous tumor which is rich in vascularity. I had one referral from my own professor elsewhere, a retired professor, and they thought it's arteriovenous anastomosis. Actually, it was scar ectopic, a very vascularized scar ectopic, and they did not find a fetus there, not a sac. It was just a homogeneous mass and was wrongly diagnosed by somebody else, and my professor said, something is wrong with the diagnosis. And I said, yes, ma'am, it's not at all AV fistula. It is basically a scar ectopic, which is kind of vascularized sometimes. So these are all the various issues. It just keeps coming all over. And what do? You either, I give methotrexate or I remove laparoscopically. Only two things can be done. But people have done some hysteroscopically also. They have removed hysteroscopically. They have removed, I don't know whether Alka madam has done that. Hysteroscopic removal, I have never seen or done. But people have even advised that. But I think it's common sense to do it properly. Open at least do laparotomy or at least do laparoscopy and remove that. But I have done few cases with methotrexate. I had one more patient with a heartbeat, cardiac activity present, because I am also good in embryo reduction because I do IVF and embryo transfers and I do get multiple pregnancies, and I have been doing many embryo reductions those days. So I just put potassium chloride to this scar ectopic, to the heart, and I gave a methotrexate. It just disappeared in 1 or 2 months. So that means another possibility. But remember, if it's a large one, a very vascular one, you can try that, but I think better to do open and remove. So the least invasive approach should be considered first. But if you find less than 7 weeks, methotrexate provides a choice of treatment in stable patients who wish to preserve their reproductive ability. Less than 7 weeks, and the beta HCG should be less than 5,000, and a small 2.5 centimeter mass. Only no cardiac activity. In all those patients, you can give methotrexate. Otherwise, I think better to open and remove. People have tried transcervical resection, but I don't recommend all that because hysteroscopy, laparotomy and all that is not necessary. We'll skip that. So now, you will find, I think we'll skip these things because of the time factor, but I'll just go and tell you a few things. Another problem is scar dehiscence. Again, so many scar dehiscence. Different names, everybody has a pet name. Like that, this scar dehiscence, what we were thinking only dehiscence, now they're talking about, they call it isthmocele. Isthmocele, another nickname is niche. Everything is same. Niche, my patient has a niche. I'm wondering what it is. It's just an opening. Once again, although Caesarean scar defect, also called niche or isthmocele, is visible on ultrasound, very easily visible, although it may remain asymptomatic, several series reported an association with abnormal uterine bleeding. They go on bleeding all the time. And you have to do proper repair again, and they all get into problem with bleeding, and sometimes they become pregnant, it's even worse. So abnormal uterine bleeding, most characterized as postmenopausal. Spotting is the main symptom. It's not the whole month. They'll just get menstruation, post-menstruation, from 10 days they'll be spotting. Several surgical techniques have been developed, including laparoscopy, hysteroscopy, and so on. And of course, uterine rupture and Caesarean scar pregnancy is a problem with all these kind of things. So this is one of my patients which I have done recently, and they referred to me with this kind of an opening there, and complete opening. I put an arrow there. Whole thing was open. So I did actually laparoscopically, I sutured that isthmocele in proper one layer itself. I had to put 2 layers in between here and there, but generally it should be repaired properly. Don't leave it like that. So, a post-Caesarean niche, an update. Interestingly, is the iatrogenic pouch-like defect at the site of previous Caesarean section. Other terms I just mentioned, and usually from the triangular or hypoic area, as I mentioned to you, and indentations of at least 2 millimeters depth into the myometrium. It should be at least 2 millimeters into the myometrium. Sometimes a small one, nothing need to be done. 2 millimeters for sure, it is a isthmocele. Now, factors affecting the lower uterine segment. It's all because of our wrong techniques. Cervical dilatation more than 5 centimeters, advanced fetal stage, head in the pelvis. You're not taking a proper decision to do Caesarean section. full dilatation, you have done a cesarean section, and you have not sutured the uterus properly, they all have ischemic seal, a good number. The level of uterine incision is important. Lower uterine incision towards the cervix results in poor healing, as mucus secreted by the cervical glands interferes with myometrial approximation. The cervical mucus gradually increases the niche also. I was taught by my Dr. Padma Rao, she said never put too low incision. Just open the lower segment, just open the UV part, push a little bit, deliver the baby. Some people will push that bladder so much, they want to put a low incision, it will be on the cervix. So do not do those kind of heroic surgery. I am calling heroic because it's not necessary to do that. So just put an incision lower segment and don't go too deep down, because the healing is poor and the mucus will go on getting into that area and cause ischemic seal. That's another thing I wanted to mention. All cesareans done in a second stage or end of first stage, please remember, take care of the scar, put a proper incision and proper suturing. So this is one ischemic seal I had done it recently, and this ischemic seal was interesting because it's completely open scar, and I just had to open it and suture like that, and it was quite an easy job. So we sutured this effectively, and now she became pregnant after about 3 months of my surgery, and she's continuing her pregnancy now. That means a good suturing is very, very important. Now this is important. We were taught 2 layers for all the years. Suddenly people said single layer. That is not necessary, and do not lock that uterus. Single layer deciduous sparing closure techniques predisposes to incomplete closure compared to single full thickness closure, means you could do it in 2 layers. 95% patients with niche had a single layer closure without closing the peritoneum. We don't close the peritoneum most of the time. Of course, at least proper muscle suturing must be done. And one thing is, the locking. I was also locking, but I don't lock. I don't do so much cesarean these days. But I think if you go on locking too much also, it will interfere with the blood supply. You may lock, maybe 1 layer. Other layer should not do, because even locking can strangulate the muscle and the healing becomes very bad. So proper approximation is very, very important. Don't be in a hurry to do. I'll never forget, when I was a very junior staff, I had a placenta previa case, and I have not handled that time. I just passed my MS and I had nobody to help me at that day. And I opened and delivered the baby, and she was bleeding profusely. I just wanted to close something to something, and I realized I closed the posterior edge of the posterior wall to the anterior wall. And that's a bad surgery. I recognized that, and I put my finger from below and said, I think I've closed the cervical canal. I closed the uterus. So these kind of wrong techniques, because I diagnosed that, I reopened it and sutured properly. I always tell young ones, when I do cesarean, I show them posterior ridge. If it's very prominent, you may suture that, not intentionally, if there's bleeding. So if your wrong technique of suturing can cause havoc and defective scars. So non-perpendicular sutures leading to an irregular myometrium, T-shaped, all that people are taught, difficult mean do T-shaped uterus, very bad. All these locking sutures are very tight second layer leading to ischemia necrosis, result in poor healing. Thus, a double layer closure using non-locking sutures is the optimal closure technique that results in thicker residual myometrium. So I think these are all the iatrogenic problem. Now one more thing I'm finding is, cesarean section done in a hurry, they'll come back to me for another embryo transfer. My own IVF pregnancy, they go and deliver somewhere else. When they come back for the remaining embryos to be, I cannot put it. The whole uterus is stuck to the anterior wall, and the whole thing has become retroverted, retroflexed, and it's a very difficult situation. So I think once again, all this scar formation is because of bad techniques. Retroflex uterus, impaired healing, poor hemostasis, and so on. If they have diabetes in pregnancy, and all this becomes even worse. So medical treatment of this will be hormonal therapy, symptomatically relieves, as I mentioned. Oral contraceptives are suitable. Uterine sparing surgical treatment, and of course we can remove or repair any technique by any method. Another one I am finding is scar endometriosis. Why the scar has to get endometriosis? We were all taught that there is a fistula. It's not fistula. It is what we have done the cesarean section. We are inoculated that endometrium into the scar. We have not washed properly. the inoculation of the endometrium will cause scar endometriosis. That is why I am saying there is no fistula anymore, we cannot find it. It's a wrong technique of cesarean section scar. Hence, they'll come with intermittent pain in the lower abdomen, and they may come with some bluish discoloration, and they may sometimes have severe pain. So remember, scar endometriosis can be clinically misdiagnosed as hernia or an hematoma, and all these problems are in plenty if you do not do a cesarean section correctly. They come like that with a big mass like on a corner there. I have dealt with many such patients, but I just want to emphasize that scar endometriosis is all because of our faulty technique of cesarean section. The placental adherent to the scar also is another problem. I always say if there is a placenta previa, rule out placental adherence because that is an important issue. If you look at the diagram there, I've drawn a little dotted line. The one is the presence of irregular sign in a case of adherent placenta. That means you are not finding it properly. The next one is good. The right one, beautifully you can see the placenta away from the cervix. So if you don't find that regular margin, it becomes irregular, you must suspect adherent placenta and get a proper Doppler assessed also. Of course, rupture uterus, I'm not going to talk about, all because of faulty techniques and so on. Now, coming to the important point, just because we have done a scar and repaired all that, she become pregnant, do not ignore preterm labor. They'll get into preterm labor. We have been taught that without reason they can get into preterm labor. But if you've done a scarred uterus and they become pregnant, you repaired it, yet they can get into preterm labor because they all have connection of poor healing. So international guidelines have clearly said if you have a scarred uterus or not a scarred uterus, at least measure the cervical length by at least 13 weeks and by maybe I do it around anomaly scan also. And Deepika would agree with me that cervix has become a routine measurement for all pregnant women so that we don't get into preterm labor. But I would like to tell one thing, all this is gone. Trust your vaginal ultrasound. We were only teaching this much. Trust means T, your is Y shape, V is V shape, means the membranes are already bulging into the cervical canal. That's late. What we should now do is if you have a scarred uterus and you repaired it and become pregnant, at least look at the cervical length. You know, we are talking about Holi, Diwali, and I was greeted by ma'am with all the lovely colors. And, you know, I like to see the diya. The diya is like that, isn't it, for Diwali? Why I am bringing that today? Look at the cervix. The cervix should be like a diya. It should be curved. If the cervix is not curved, it will open up. The length is important, but if the cervix is like that, like a diya, it won't open. So always say the cervical length is important, but the shape, the cervix should be like a diya, and that is a good point because that cervix will not open and she will not get into preterm labor. So another interesting sign is, this has been missed always. Look at the picture there. The internal os, the membrane should be on the internal os. If the membrane has come out a little bit, that will rupture the membrane. That is why all these scarred uterus, when they get into pregnancy, that portion is a weak portion and the membrane may open up and they suddenly rupture the membrane. So the cervical length should be good, and of course moon sign of a membrane is bad. So a lot of reports have come up by saying oral micronized progesterone is good for preventing preterm labor, and it is effective in preventing the spontaneous preterm labor. The additional advantage of oral administration, affordability, and high safe profile, making it worth recommending at least for further research. Now, what is again forgotten is, if they come in preterm labor, you're giving nifedipine, but don't stop it like that. You have to give maintenance tocolysis. Maintenance, I don't give any more injectable of very painful injections. I do give sometime, but because the new introduction of the micronized progesterone, I just give 200 milligram at night, once a day as a maintenance therapy. It's pretty effective. But if you find the cervix is very short, you must add on intramuscular progesterone also. So when you compare natural micronized progesterone to synthetic progestogens, there's a lot of difference because the natural chemical structure exactly equivalent to endogenous progesterone. Micronization improves oral bioavailability, making oral administration possible, and it's a category B drug. No effect on the mood. I had one ophthalmology patient. She had a previous problem, then she became pregnant, then her cervix was short, and I was giving her some medicine, some tablets, injectable, I think she was taking. And she was also taking a lot of progestogens. And her boss called me and said, I think your patient is not operating properly. She's not able to, she's sleepy. And she came and said, my madam is saying I'm not working properly because I'm very drowsy all the time. And I'm drowsy because of too much of progestogens. Everybody gives 2-3 kinds of progestogens in pregnancy. And I told her, I didn't give you that. She said, no, she was going for antenatal checkup somewhere else. I said, stop all that. You don't need any of those. Just take one of these oral at night, not in the morning. Night you take, you'll be fine. And she was perfectly fine. Her boss appreciated a little change of medication. And that's what I sometimes feel, simple things are good. The sustained release basically is progesterone release in the upper GIT, which helps to prevent pre-systemic metabolism at several successive steps at intestinal bacteria, intestinal wall, and of course the liver. That means this absorption, lymphatic absorption limits first pass metabolism. I've adapted from the Foxy recommendation, November 2019. They have recommended systemic, so basically the release of sustained release, gradual dissolution and erosion of polymerase matrix facilitates lymphatic absorption and of course limits hepatic first pass metabolism. So basically the sustained release is quite pretty good in affecting tuberculosis also. Hence, progesterone in all these scarred uterus, and when you suspect preterm labor, you should give them progestogens because it acts on the different areas, uterus, membranes, placenta, and amniotic fluid. It's not the only progesterone, you should also rule out infections. It is completely missed in clinical practice because I feel anybody with discharge, people have forgotten to put a speculum. My residents have never seen a speculum, I'm sure. They only do ultrasounds. And pelvic examination is forgotten totally. They have not palpated nor anything. So I feel all these scarred uterus patients become pregnant or they are all high risk, ma'am. If there is discharge, you have to treat them effectively and give them probiotics. I think that's a very simple clinical scenario. When you suspect somebody getting into preterm labor, just give progestogen, sustained release, give them this kind of, I give them one fenticonazole. Just one 600 ml fenticonazole, I give the probiotics, I give them, they are pretty well, they don't have preterm labors. Because the lactobacilli acts in so many things like lactic acid production and so on. All these helps restoring, maintaining normal flora. So a lot of things happens when you give these kind of lactoferrin, anti-inflammatory effect, antioxidant properties, antimicrobial, etc. So to conclude my presentation, scar on the uterus, concerns and challenges. I brought in a lot of our own clinical practice. I made a proper 25 minutes presentation. Several conditions causing scar uterus. Understanding the various problems are essential for the management strategies.